What are some of the other challenges with interpreting and then utilizing genetic information, other than the fact that 180 of these tests aren't useful right now at all?
Fair question. We've talked earlier today about using KRAS in colorectal cancer in those individuals who possess the KRAS wild-type mutation can and do benefit from drugs such as cetuximab and Vectibix. But you can also see KRAS in other disease states, in head and neck cancers, in lung cancers. We don't know if the KRAS that is present in those folks is the same KRAS that's present in colorectal cancer. And to try to extrapolate and says all KRAS is equal is not the proper way to go.
Got to
We
do
need
research.
data.
Got to get data. Maybe you guys should pay for that data. You're going to pay for the drugs.
Maybe we should.
And maybe you should.
Maybe we should.
What are the challenges associated with Medicare reimbursement policies with all of this?
Well, Medicare, especially with the sequestration back in, I think it was 2013, or maybe 2012, I don't remember when that hullabaloo hit, cut everything back, and it kind of put a halt on a lot of research. It certainly hurt the practicing medical oncologist in the community by taking 2% off of their already scanty reimbursement for drug cost. So I think that has hurt innovation to some extent. And hopefully with the restoration of Cancer Care Act that's been going through Congress now for the last year or so, maybe some of that will be restored, but for the time being, it's serving as a crimp, no question.
Well, now these newer drugs, the newer technologies, are increasingly expensive. One way that healthcare plans have adapted to this is, surprise, surprise, increasing patient cost sharing, right? Raising premiums, raising copays. This can definitely impact patient decisions to continue treatment. So what do you see in terms of policy changes, other than raising premiums, that can help to cover all this?
We can't continue to raise premiums indefinitely. I think there's got to be some culpability on all the stakeholders in this situation. And what we are looking at, and to digress for 1 second, is that by raising and by keeping these copays, keeping these costs as high as they are, you're disincentivizing people to get treatment. They can't afford the treatment. And there's lots of studies and data to show that what happens with the accelerating cost of these drugs. So what we're one of the things that we are looking at doing is an all-encompassing payment with one deductible. It's something that's in the discussion phases. We're talking about it with some employer groups, with our national teams, to see if by one deductible, one copay, and covers their entire treatment. So it's not every time they go to the doctor or to the hospital, it's $150 here, $200 here, and same thing with their prescription drugs.
Let me frame this very clearly. The disincentivization for people to seek treatment because of the copays really means they're not going to get treatment for a potentially fatal disease, cancer, disseminated cancer. That translates into death, unpleasant death. So what you're telling me is that if people continue to be disincentivized because of money, those people will die faster. Yes?
Well, it's not only for advanced and metastatic disease. We see this problem in the adjuvant setting as well.
Okay.
There's adjuvant, intravenous, parenteral chemotherapy. There's adjuvant oral agents. It's the same thing.
But they all have one thing in common. Whether it's adjuvant or treatment for advanced disease, it's to keep the cancer at bay.
Correct.
And if you skip these treatments, that cancer is potentially let loose.
That is correct.
And let loose cancer, let's just make it very simple, that's bad.
No question about it.
All right. So it's not like, gee, I don't want to pay the copay for my car insurance. I'll live with the scratch in the door. This is, I'm going to die, potentially, if I don't make the copay. Something's got to change here, right?
Absolutely. But it becomes a question of the copay, or it becomes a question of food on the table, light bill, gas in the car. It's a very difficult situation, and that's why we're trying to work on these solutions.
And those who are interested in healthcare reform, however it looks, cite this as one of the critical points, that nobody should ever have to make that decision. You should be able to have a health care plan that covers this without sacrificing food or clothing or shelter.
I would agree with that. I mean, in a best world situation, that is true.
Okay, thank you so much for joining us.
My pleasure.